eCancer Television now continues with more news about radiation and very appropriately from Professor Dr. Ritsuko Komaki from the MD Anderson Cancer Center in Texas. And Ritsuko, you've just come back from Japan, where you've had quite a bit of experience of the earthquake and the risks of radiation. And it's risks of radiation that you're particularly interested in, and that concern the study that you've been presenting here at the ESTRO meeting. Can you give me some background on this?
Yes, since I was a child, when a friend of mine died due to leukemia, exposed to atomic bomb and developed leukemia, I was always interested to avoid low dose of radiation to children and also young adults. And when I went to MD Anderson Cancer Center 24 years ago, around that time we still had, we call it two-dimensional radiation therapy, which caused a lot of damage to the normal tissue. And more, I developed 3D conformal radiation treatment to give higher dose to the cancer, but less dose to the surrounding normal tissue. And then eventually, intensity modulated radiation therapy, that's the better way to give higher dose of the radiation to the tumor to control cancer, but not to give large dose of radiation surrounding normal tissue. But then IMRT, intensity modulating radiation treatment, it does give some low dose of radiation to the bone marrow or even total body radiation. That's the major concern for children. So the proton beam treatment, that's the best way to avoid low dose of radiation to the normal tissue, but gives very high dose of radiation to the tumor.
Right, now you've got a personal dimension because you're originally from Hiroshima, so
Yes.
these things really matter to you.
Yes.
And you have now been comparing three modalities, the conformal radiation
Yes.
with the intensity modulated radiation, and finally proton beams. You're doing this in a locally advanced non-small cell lung cancer.
That's
Can you
correct.
tell me what you did in this study and a little bit about the differences, the physical differences between the proton beams and the two X-ray modalities?
Well, when we started to do three-dimensional conformal radiation treatment, we reduced much toxicity surrounding normal tissues such as lung and the esophagus, bone marrow, and then we found conformality, which means the tumor, the volume, and also the shape. It's not really square, it's an irregular shape. So intensity modulated radiation therapy gives much better conformality. That means it avoids any hot spot in different areas. And then we started to treat the lung cancer, which is the leading cause of cancer deaths in the United States and the rest of the world. And IMRT is better than 3D conformal radiation therapy in regard to tumor control and less normal tissue toxicity. But we started to do proton treatment.
What's the difference between protons? Because protons are actually heavy particles, so they travel differently in tissue, don't they?
That's a very good question, because the proton, we use Bragg peak. Bragg peak gives really low dose when it enters to the skin and deposit 100% energy into the tumor, and there is no exit dose, it drops. And that means when we use multiple field, IMRT gives very low dose, scattering around the surrounding normal tissue, but the proton treatment, it does not give that low dose exit dose, and also the entrance dose is very low. And we use spread a Bragg peak, and because of the advancement of physics, now we can shape and we can treat much larger area by the proton.
And by adjusting the energy of the protons, you can be very precise about
Yes.
these things, can't you?
Yes.
And can you give me the figures then? What came out of your study in lung cancer in terms of esophagitis, pneumonitis, and bone marrow effects?
Well, like pneumonitis, when we combined proton beam and concurrent chemotherapy, that's what we usually do, stage 3 non-small cell lung cancer, which cannot be removed. And the pneumonitis became only like 2%. And
That's a big difference.
Compared to like 9% of the pneumonitis by IMRT, and the 3D conformal, that was like 32%.
What about esophagitis and bone marrow effects?
The esophagitis was also only like 4% by the proton treatment compared to IMRT, which gave like 10% of the esophagitis, severe esophagitis. That means patient cannot swallow.
Now, it's looking very promising at the moment in favour of proton beam therapy. Of course, there must be a price tag attached to this, but we'll perhaps talk about that later. But what, in a perfect world where you could use any modality, what would be the recommendations?
Well, eventually, the cost of the proton treatment will become much less. When we started to do IMRT, it was very expensive because it took much time, and also we had to train the medical physicist. And now it's very standard, certain areas. But the proton beam, once it gets to become like standard, it will get much cheaper. In the United States, proton treatment is standard for prostate cancer and the pediatric, and the insurance will cover, and also proton beam treatment is covered by the Medicare. So it will become much cheaper later on.
What message then would you like to give to doctors that can be of use? I mean, clearly it seems that the IMRT is a big step forward, and looking to the future, depending on the facilities, it seems as if you really can spare normal tissues very effectively with the proton beam therapy. Is that a done deal now, or do you need to do more investigation?
We have to think ahead. All the science is evolving, and we started to make longer life. Those patients who had lung cancer, it used to be death sentence, and nobody lived really long time, and we did not worry about the late effect, and that's not the case anymore. And about 40% and getting close to 50%, we started to prolong the patient with lung cancer, and that means those patients who live long enough, they're going to develop second malignancy if we scatter low dose to normal tissue.
So X-rays can cause a lot of damage,
right.
and you can, what you're saying is you can be really precise by using the protons.
Right.
So, an even better step forward than merely controlling the existing disease.
Right. And we are very concerned about the damaging normal tissue, which patient will suffer if they survive from cancer. They have to be with oxygen, and they cannot swallow.
Sure.
And the quality of life we can improve by proton.
So what's the take-home message for doctors then?
Okay, so proton beam treatment, it will improve the patient quality of life in addition to prolonging their life free of cancer. And that's what my take-home message.
Thank you for joining eCancer Television.
Thank you so much for inviting me.